Good afternoon, everyone, and hello from the UCLA Center for Health Policy Research, where as a land-grant institution, we acknowledge the Gabrielina Tongva peoples as the traditional land caretakers of Travangar, that is, the Los Angeles Basin and South Channel Islands. Thank you for joining us today for this webinar featuring some excellent work in advancing data disaggregation. I believe I am probably preaching to the choir when I talk about the value of data disaggregation and the benefits of improved representation in racial and ethnic subgroups. Many of you also know that increasing disaggregation can be complicated and, annoyingly, often expensive in data collection. The Robert Wood Johnson Foundation has a mission to improve the availability of disaggregated data and therefore highly representative data to be used by researchers, policy leaders, and most importantly, the community groups that are working to advance health equity. They supported this project as a way to demonstrate that for modest investments, great advances can be made. So today, we welcome Lindsey Whittington from the Colorado Health Institute. They run the Colorado Health Access Survey, or CHAS, a population health survey reflecting the health of Coloradans. A few years ago, Lindsey and their team recognized that there were many Latinx communities in the state that were not fully represented in many important data sets. And while they could control measures in the CHAS, there were other very important data sets out there that did not include these measures, including the Colorado Health Observation Regional Data Service, or CORDS, and the Colorado All-Payer Claims Database. So today, Lindsey, a self-proclaimed data nerd, will reveal how they expanded the CHAS to include many Latinx subgroups and built a model to apply the power of the CHAS to other data sets to help glean understanding of those subgroups in the context of the CORDS and the all-payer database. Once they applied the methodology, they were able to offer data insights into that data that did not previously exist. The results have excited so many community groups in California that now have access to data on specific groups that wasn't there just a year ago. So we are looking forward to seeing what some of these groups do with the new data and the health outcomes they are able to achieve. But Lindsey already did a webinar releasing the data and those results. We're going to put the link to that in the chat. Today, we are looking at this methodological advancement, and we want to gain insight into the methods that they applied and learn how you may be able to adapt this methodology to your data needs and the wonderful outcomes that they were able to achieve that you may be able to replicate for your needs. We welcome Lindsey.
That was a great intro, AJ. Thank you so much. Hi, everybody. I'm super excited to get to chat with you all today about something I've been very honored and very passionate to be able to work on the last 3 years, over 3 years now. But I also wanted to say I didn't do this project all alone. I wanted to give a shout out to Dr. Emily Bacon and Anna Furness, two people that really helped guide this work with their thoughtfulness and supported me throughout the model development phase. Also to Robin Meneses and Guadalupe Solis for their support and leadership of the community engagement strategies throughout this project as well as to Jeff Bontrager, who got us involved in this work in the first place. So thank you all for your contribution to this work and everything that you do. All right, so let's get started. This work we'll be talking today about a project that has partners and interests that extend beyond Colorado's audience, which is really a cool part of this for me because most of the work I do is involved just in Colorado. But for that reason, I wanted to introduce where I work, the Colorado Health Institute, or CHI, to everyone on the call today. So CHI is a nonprofit, mission-driven public health institute. We work to advance health equity and well-being in our communities throughout using research and data-driven approaches, as well as through convening of many important stakeholders in the public health space in Colorado. We have been working with community groups, government agencies, providers, and foundations for more than 20 years, providing trusted analysis and data around strategic planning, facilitation, complex modeling, and evaluation, among other activities. So feel free to reach out to me with any questions about CHI or if you would be interested in collaborating in the future about any important work that you're working on. All right, so like AJ mentioned, let's now introduce ourselves. If you all wouldn't mind dropping in your name and what organization you are with and representing today, that would be great. I'm super interested to see who's joining us all today. So if you guys can just pop into the chat, let's see who's joining us throughout the country. Denver Health, SHADAC, Illinois Department of Public Health. Welcome, everybody. CDC. We got some all-payer claims folks on the call, university folks. Wow, we got a great spread from people from all over the country. This is super cool. Thank you all for joining us today. I'm just really excited to share this all with you and all the other important work that you're doing. All right, so now I'll introduce myself. AJ did a little bit of kind of my background, but again, I'm Lindsey Whittington. I am the data and analysis manager at CHI, and way back in the day, I started my journey in science and biochemistry, and it eventually, I transitioned to public health and got my master's in public health and epidemiology in 2019. And since then, I've been working at CHI, where I have supported and led a whole host of quantitative and geospatial analyses, and have become the data manager of the Colorado Health Access Survey, which is one of the primary data sources that we will talk about today about this project. So welcome, everybody. Thank you all for participating in that. All right. So I'm going to start us off by introducing everyone to the different phases of work that spans over the last more than 3 years now. The presentation will also follow these 3 phases as we move through all the different things that were created throughout those 3 years of work. So to start, I'm going to, I'm going to take us through that project history, and then I'm going to go through the methodological development and kind of the things that we did to develop the methodology that AJ spoke about earlier. Then we're going to actually go a little bit into some of the application of the methods and results. Again, we have a whole webinar that we will also share with everybody that goes through more in depth about those results. And then we're going to walk through all of the different things that we did to involve community and to make sure that we uplift the community voice in this project. And then AJ and I are going to kind of open it up to discussion and talk about next steps together. So back to that project history. In the first phase, we began this work in the fall of 2020, and it led into the summer of 2021, where we worked with the UCLA team to understand what methodologies are possible to investigate in Colorado based on the data that is available here. This work culminated into a feasibility assessment, where we provided different examples of ways that researchers and others could pursue data disaggregation based on the kinds of information that is available in your own data sets. We also outlined a case study where we outlined our proposed methodology to disaggregate data based on our own data systems in Colorado, but we also wanted to use this as kind of like a template potentially for other states and other entities to use as well. And during this phase, we also began collecting disaggregated racial and ethnic data on the 2021 CHAS in preparation for future phases of work. So we didn't just collect on the Hispanic or Latino community, we also added a whole host of disaggregated ethnicities and racial groups under Middle Eastern and North African. We also added that, as well as other groups that are categorized within the overall OMB racial and ethnic categories. So after that phase, this led us into phase 2, which kicked off in the summer of 2021 and then led us into January of 2022. And this phase of work applied that proposed methodological approach from that feasibility assessment in phase 1. And in this phase, we built and tested a series of logistic regression models to disaggregate data across Colorado's data systems, which we'll go into more in depth. And the result of this phase was that methodological report, which I will be sharing mostly about today. And then lastly, we applied those best performing models from phase 2 in our last phase of work, which is really around that application and looking at results. So this phase allowed us to then report on disaggregated data and provide information about behavioral health access and diagnoses within the Hispanic or Latino community. So I will share some of those results with you all today. And then I will also speak to the community engagement strategies that were pursued throughout all 3 of these phases. So I save that for the end to kind of talk through all of those different kinds of engagement strategies. But let's start with what we learned in phase 1 to understand the kinds of methods for disaggregating data and what's possible in Colorado. So in phase one, we investigated what data sets were available that we could use for possible methods to disaggregate data across them. So based on that investigation, we identified 3 important data sets that exist in Colorado that have a whole range of information available within them. And those data sets include the Colorado Health Access Survey, or the CHAS, the Colorado Health Observation Regional Data Service, or the CORDS, and the Colorado All-Payer Claims Database, or the APCD. And so let's take a look at these 3 data sets more in depth. So first off, the Colorado Health Access Survey. This is called the CHAS, and it's a survey that CHI has fielded since 2009. It is fielded biannually and is a random sample of over 10,000 Coloradans for every survey year. And when we started this project, we were in the process of developing the survey tool for the 2021 survey. And this put us in a great position to expand our racial and ethnic survey data that we were collecting on. So that's what we did. We started collecting disaggregated racial and ethnic data based on recommendations from community groups that represented each of the overall OMB categories. We also added a Middle Eastern and North African category, like I mentioned earlier, as well as disaggregating identities within that population. But like AJ mentioned, for the purpose of this project, we really focused on data availability within the Hispanic and Latino community in Colorado, because they make up about 1/4 of our population overall. So then we have the All-Payer Claims Database. The Colorado APCD is stewarded by the Center for Improving Value in Healthcare, or CIVIC, which is a nonprofit organization that works to empower individuals and communities and other orgs with collaborative support services and healthcare information to advance health. The APCD is a comprehensive claims data set which represents most insured people in Colorado and includes more than 40 commercial payers. So this is a big data set. It has lots of rich information, and it covers a large swath of individuals that are accessing health in Colorado. And then lastly, we have the CORDS data set. The CORDS is actually a network of health systems and providers that use electronic health record data to identify health trends and support public health evaluation and monitoring efforts in Colorado. It includes 14 providers and health systems that participate in it. And the CORDS network supports chronic disease surveillance across Colorado counties. It mostly covers the Metro Denver area, which does include a large portion of our population, but it doesn't cover the entire state. And they only collect on aggregated data around racial and ethnic categories. So once we kind of investigated these 3 data sets, we wanted to know, what can we actually do with these data? So the CHAS is the data source that has that collected data of the Hispanic and Latino community that we were interested in disaggregating across the CORDS and across the Colorado APCD data sets. However, the CHAS does not collect on any personally identifiable information. So using some disaggregation methods like data linkage was not possible for us in Colorado. So instead, we had to take a different approach to be able to actually disaggregate the Hispanic and Latino community within the other 2 data systems that we were interested in. So this led us then to pursue the method of predictive modeling to make this happen. So this actually leads us to the next phase of work, where we developed those predictive models, that methodological development approach. And again, that's that second phase of the project history. So based on our proposed approach, from our analysis of those data sets in phase 1, we needed to investigate what covariates were available across all these 3 data sets that we could actually use to build models. So we had to be able to harmonize the variables within the data sets to match the definitions that we use in the CHAS, to apply those to then actually build these models in the CORDS and the APCD. Because each identity is dichotomous, a logistic regression modeling approach was chosen to estimate the likelihood of the identity as the primary outcome for each of those different regression models. This means building and validating the models using the CHAS and applying the high-performing models to the CORDS and Colorado APCD datasets to look at the outcomes we were actually interested in. So let's walk through those methods, that approach that we did, to take a look at some of the findings from the methodological development phase. So again, our first step was to understand what data we could use to harmonize across the 3 data sets, and if there was any information that was available that we could use for additional validation steps to validate that our models are actually doing a good job predicting our outcomes of interest. So this really limits us when we're thinking through across all these 3 data sets, what kind of information is actually shared across these systems so that we can actually build models. We have to make sure that the information that we have in the CHAS is something that we can look at in the APCD and something that we can look at in the CHORDs. So this table outlines the data measures that were available across all of the 3 different systems. The first of which are really common variables across all 3 types. And this include things like race, the overall race, age, gender, urban rural status, as well as insurance coverage type. So those were the main covariates that were available across all 3 of our data systems. There was also some data metrics that were also of interest that were shared either between the CHAS and CHORDs or the CHAS and the APCD. So within the APCD, we found that there was a variable that they collect on some disaggregated data on ethnicity and ancestry. So we wanted to investigate if it was possible to actually use that information to validate our models. But unfortunately, data was highly variable and quality and availability of it in the sample was very variable. So we decided not to heavily rely on these data to validate our models. But very interestingly, there was an additional metric that was available within the CHORDs that was super interesting to have. And this was language spoken at home. This was an additional metric that we wanted to include. So we decided to build 2 sets of models that would be applied to the APCD, which doesn't have that language variable, and then another set of models that we applied to the CHORDs that do have that language covariate. So we realized in this step, we had to kind of branch off and build 2 different modeling approaches, one for the Colorado All-Payer Claims Database and one for the CHORDs, because we have a little bit of different information available across those data sets. So this culminated all together, and I'm just kind of outlining the data source, the different variables that we then included to investigate for our model development, as well as our primary outcomes of interest for each of those models. So the main data source, again, we built the models using the 2021 Colorado Health Access Survey. The covariates that we investigated in those logistic models include insurance type, language spoken at home, again, only in the CHORDs models, race, which we included as not mutually exclusive, gender, urban rural status, and age. And then we built individual models for each of the different identities that we disaggregated on the 2021 CHAS. And this included Mexican or Mexican American, Chicano, South American, Central American, Latinx, Caribbean, and Spanish American. So we built individual models for all of those different identities. Half of them, or not half of them, we built them one set for the CHORDs to be applied to the CHORDs and one set to be applied to the all-payer claims database. So now I'm going to kind of walk us through the steps that actually made this happen when we developed the models. So first, we took the CHAS, the 2021 CHAS, and we built it where we separated out a training data set, which is what we actually build the model on, and then a validation data set. So we basically take the sample, split it up so that we have 2 different data sets to both build the models and to actually validate the models at the end. So after we split them up, taking that training data set, we then did a univariate analysis. So this just means I took all of the different metrics that we had that we wanted to investigate, and I investigated if it was statistically related to each of the different identities that we built the models for. So for all 6 identities, I tested all the covariates to see which ones just by itself were statistically related to the outcome of interest. So once I figured out which ones were statistically related, I then went to a stepwise model selection process. So for each of those 6 models, I then added each of the covariates that I found in the univariate analysis to be related to the outcome. I then added each one of those in there in a stepwise model selection process to see which ones increased fitness of each of the models as I did that selection process. And once I did that, we then had to do model fitness testing. So then really understanding how well are these models performing on the training data set, and then actually validating the data set using those models, applying them to the validation data set to see how well they're actually predicting the outcome of interest in that validation data set. So lots of steps here, but really it just was building the models in the top steps and then actually validating to see how well are they actually performing and actually predicting the likelihood that someone on the CHAZ is each of the different identities that we captured within the Hispanic or Latino community. And once we actually validate all the different models and figure out which ones are performing well, that's when we do the application step and take those logistic models and then apply it to our 2 data sets, which was phase 3. But everything that we're going through step 1, 2, 3, and 4 was everything that we did in phase 2. And all of this is very detailed and outlined in my methodological document that kind of tracks on this work that we did. So this table just outlines kind of the final models and what covariates were included in both the CHORDS dataset models as well as the all-payer claims dataset models. So we did all model creation using the training datasets again. So after univariate analysis on the training datasets to understand which covariates were significantly associated, we did that stepwise model selection like I mentioned earlier. And the final results of those tests are included in this table. So I won't read them all out. These are just mostly to refer to for later for everyone. But again, we developed the models that were fitted to be applied to the CHORDS and the all-payer claims database. So these are kind of the final models for each of those identities, each of the 6 identities, and which covariates are actually included in each of those logistic models. And in my report, I have all of the different the models themselves with all the different numbers and also the model output as well. So people can check that out as well after the presentation. So once we actually built all the models, this is where we had to do the validation step. And after creation of the models on those training data sets, we then applied all of those models to the validation data sets that were created to really understand how well these models were performing in estimating the likelihood that someone within the validation data set actually identifies as one of the Hispanic or Latino identities. So we used a couple important statistics to understand how well these models were performing. So we created receiver operating curves for each of the different models, which helps us identify how well the model detects that someone is the identity of interest, and also how accurately it rules out that someone is not that identity. And we also use the area under the curve statistic, which helps us understand if our model is actually distinguishing our outcome of interest. Random chance of the outcome actually occurring represents a statistics of 0.5, which means that the model isn't predicting any differently than just random chance. The farther away that statistic gets from 0.5 and closer to 1, the better the model is predicting the outcome of interest. And that last statistic that we had to use was the optimum predictive threshold. And this allows us to understand at what point the model was predicting the outcome with the best sensitivity and specificity, which relates to the true positive rate of the outcome and the true negative rate of the outcome. So again, all of this taken together, these statistics are just really telling us how well are these models actually predicting each of the identities and how well does it actually predict that likelihood. So this is just some examples of the output that I have in the paper. So this table brings together all of the statistics in one place. So if we check out the area under the curve values in each of these different identity models, we can get an idea of how well those models are performing when applied to the validation data sets. So for example, in this orange box here, I'm showing the South American models for both CHORDS and the APCD. And for this specific model for the CHORDS, we got an area under the curve value of 0.7, while we got an area under the curve value of about 0.68 for the APCD models for this specific identity. And how we kind of interpret this is based on a scale of these values. So for example, a scale that shows an AUC value of 0.7 to 0.8 represents like acceptable distinguishing power of the model, and anything above 0.8 is like excellent discrimination, where it's talking about like it's really good at distinguishing the actual outcome of interest. So when we look at this table, most of our models fell within the 0.6 to about 0.67 range, so under that 0.7 threshold, whereas South American is a little bit closer to 0.7 across both data models. So interestingly, something I wanted to point out is all of the the APCD models performed less well across all identities compared to the chords models. And I think it's likely related to the addition of the language spoken at home covariate. This really speaks to the importance of inclusion of language as a covariate for our purposes, for our model development, and how just one additional demographic variable can really enhance your model development. So this got me thinking, what if we had more information? Because we were really limited to the kinds of covariates and metrics that we could actually investigate to build these models. So this got me thinking, what if we had more data? This led me to do an additional analysis, which I called the what if analysis in the report. And this got me thinking about the addition of a handful of other demographic characteristics in the model to understand implications of model development in just a few more metrics were available. If we just collected one or two more things about our different populations. So these are the three demographics I actually investigated. I investigated if we had income, if we had education, and if we had family size. And I will walk us through one example of this analysis where all three are included in the report, but I actually investigated and I'll show you the outcome of the income variable. So what if we actually had their income, if we had information about patients and others about their income? And so this table outlines the change in the area under the curve statistics with and without inclusion of income in each of the different identity models. So again, we have our 6 models on the left, and the middle column is the area under the curve values, how well it's performing in the middle. And then we have the actual addition of income. That's the area under the curve variable in the very far end. So I just want to kind of point this out. Inclusion of income in model development actually increased the distinguishing power of 3 of the 6 models. So just one additional demographic characteristic brought the South American model, for example, to excellent distinguishing power. So we got 0.8 for that AUC value. So this has implications for what information is shared across platforms and what information is made available about our patient populations. So as many systems are trying to become more interoperable, this could have implications for the kinds of information that we have available as researchers to understand more about disaggregating data. So even if a system isn't collecting disaggregated data potentially about their patients, if their electronic health record system is collecting on screening for food or housing social programs, for example, which often is related to income eligibility requirements, this would provide additional demographic information that would otherwise not be available. So this is something I've been thinking about as we move forward and think about the goal of more interoperable systems in the future. If we can get these systems to talk together, what that means for some of this research that we're doing around data disaggregation. So of course, there's some limitations that I wanted to highlight about this approach. Again, we couldn't do data linkage. We couldn't connect one patient in one system to a respondent in the CHAS, which would be the best kind of way to connect across these different data sets. So the predictive modeling approach, we're only as good as the data that we have available. And some of the models might have not had enough information included in them to really be able to have enough predictive power to really estimate these different kinds of identities that we're trying to disaggregate. So if we're very limited to the kinds of covariates, in that table, we only had like 6 covariates that we could really look at. I suspect that's why it's a lot of the models didn't perform as well as some of the other ones. And, we had to kind of make some assumptions about some of these data sets. We know that these data sets have way different populations. Some of them could be included in different data sets, but again, the chords is only the Metro Denver area in Colorado. The Colorado All-Payer Claims Database is just insured individuals. The CHAS, we have a robust sample, but we only had 1 year of disaggregated data information from 2021. So as we move forward, what can we do with more data? How can we better refine these models if we have more information about the people that we're actually trying to impact? And again, another one might be the data sets. Lots of places have all-payer claims data services, but the chords is something that's very unique to Colorado. And, what kind of information is available for other people in other parts of the country to be able to do a different approach like this. So just some things to keep in mind and something that I discuss more in depth in the paper as well. But just wanted to highlight some of these overall limitations of the strategy. And so kind of the final findings of model development, I just wanted to leave us with. that moved us forward into the actual application phase, that phase 3 phase. We were left with, okay, so a lot of our models didn't do super great, but the ones that did best were the Caribbean and Central American model, the South American model, as well as the Spanish American model. They had the highest predictive power. And so when we're thinking about moving forward, it would really benefit from additional data to be included so that we can do this for more identities, so that it's not just limited to the ones that we were able to move forward into our phase 3 analysis. So once we took all of that information, we did all of our modeling, we then moved forward and actually applied these models to the 2 different data sets, the CORDS, as well as the Colorado All-Payer Claims database. So again, that's that 3rd phase where we actually took the models, those 3 models that I mentioned, and actually applied it to the 2 data sets, and then actually looked at the information available in those data sets. And so again, the regression analysis that we were able to apply for phase 3 included Caribbean or Central American, South American, and Spanish American. So those will be the 3 disaggregated identities that you'll see throughout all the different results slides that I'm going to walk us through. So some of the guiding questions that we use for this phase 3 approach, because, a lot of the stuff that we were working on before this was really focused on methods. What do we need to develop? What are the kind of things that are feasible in Colorado? But this 3rd phase was a great use case study to really understand, well, how do behavioral health diagnoses differ among people who identify as Hispanic or Latino? How does the use of behavioral health care services differ among people who identify as Hispanic or Latino? So we really wanted to understand behavioral health care and access for the Hispanic or Latino community in Colorado, because we really wanted to take everything that we learned in phase 1 and 2 and make it really inform this phase 3. So a lot of our community engagement, a lot of the community groups that we engaged were really interested in behavioral health care access. So that really guided where we wanted to move through in phase 3. It took a lot of collaboration to come up with this phase 3 to say, what should we look at? What's most important? And a lot of community groups were telling us that behavioral health care access was a big part of what they've been thinking about. So that really informed this phase 3 and these guiding questions for phase 3. So now I'm going to walk us through just one of the results slide from our behavioral health diagnoses section, what we were able to find. And so the behavioral health diagnoses that we were able to investigate included depression, anxiety, bipolar disorder, and substance use disorder. So those are the 4 main behavioral health diagnoses that we analyzed in phase 3. So this first result slide takes us and looks at depression diagnoses within the Hispanic or Latino community. And what we found was that over 1 in 8 Hispanic or Latino patients had a depression diagnosis. And so the overall Colorado rate was about 12.7%. The Hispanic or Latino overall rate was 13.2%. And so when we think about disaggregating data, this is what we would normally see in a report. But now we have this information about 3 subpopulations within the Hispanic or Latino community. So this is where we see a little bit of variation. The Caribbean or Central American population a little bit higher at 14.3%, as well as the South American and Spanish American, right around that 13.5%. So this was really exciting to actually see all of this work come to fruition and actually see something applicable at the very end, a number that means something to people when we take it out into community. So again, the key finding here was the Hispanic Latino community, they had similar rates of behavioral health diagnoses compared to the state average, though there was differences that emerged among specific groups. So in addition to diagnosis, we also dove into understanding use of behavioral health care within the Hispanic or Latino community. So this figure outlines the average number of claims that were billed per person for different behavioral health conditions. So basically, what is the average number of visits that an individual was billed within the Hispanic or Latino community for each of the 4 different behavioral health conditions that we looked at? So depression, anxiety, bipolar disorder, and substance use disorder. So the Colorado average for each of these different diagnoses is in blue. So we can see that, An average number of visits billed for the depression diagnosis for those with depression was about 12.1 visits or claims billed. Bipolar disorder, about 16.8 billed for bipolar disorder. But then when we look within our subpopulations and even compared to the overall Hispanic Latino community, that blue bar is much higher than all of the other ones. All of the other communities, if it's just Hispanic or Latino in general, as kind of that overall group, versus our subpopulations, we can see some variability across our subpopulations. But the big finding here was that Hispanic or Latino community members were not accessing behavioral health care to the same degree as the Colorado average. So I'm going to kind of move us into now a lot of the discussion around how we did community engagement for each of the 3 different phases. So this was a really important aspect of the actual research across these 3 years because we really wanted to uplift community voice. Because one of the main things I wanted to talk about with everyone today is that data can only tell part of the story. You know, we can get lots of metrics, we can get lots of information, but what is the actual experience? A lot of the people, you know, what is the lived experience that is actually occurring for people in our communities? What is the implications of these data? So some important questions that I asked and others asked throughout the whole project was, you know, who is benefiting from this information? You know, who's actually getting access to this information? And are the people that can make decisions with this information actually getting access to it? Whose perspective might we be missing if we do not engage community, or within those that we did engage, you know, who might be missing that we weren't able to bring to the table to actually talk about this, and whose lived experience is really being centered, you know, who is this focusing on, who's actually being prioritized in these different kinds of approaches when we think about research and we think about gathering data from community. So just some important questions that, you know, we really thought through when we were thinking through this project in particular, and as well as lots of the other projects that we do at CHI. So starting with phase 1. So phase 1 really had to do with that feasibility assessment, really figuring out, you know, what can we do in Colorado, and about adding those disaggregated racial and ethnic categories to the Colorado Health Access Survey. So that was where we started off our engagement with community groups to understand what identities should be added to the CHAS for future data collection. So those 6 different identities that we actually disaggregated in our methodological approach, those were informed by different community groups to see, you know, what populations would be interesting to actually gather information on, who are our communities that we need more information on. And we also spoke to these groups to understand what the implications of having disaggregated data meant. You know, if they had access to this information, what were possible outcomes that they could actually employ? What were interventions that they could actually think about? You know, more about that implementation phase. You know, if they have this information, what could they do? And then after our phase 1 feasibility assessment, when we kicked off phase 2, we really wanted to understand from the community voice perspective, you know, what were the main issues facing the Hispanic Latino community as it related to, you know, healthcare access, healthcare, you know, when we're thinking about things that were big topics that these community groups were focused on. And that's where we figured out, you know, behavioral healthcare access and use was a big part of a lot of their conversations that they were having. So when we were recruiting groups, we really focused in on those who might serve Hispanic or Latino community members, maybe if it's more healthcare more broadly, but also behavioral health and healthcare access specifically. But we recruited a lot of people and orgs from our Metro Denver Partnership for Health network, which is something that CHI partners with all of the different metro area counties, but now it's very statewide. So we engaged with the Metro Denver Partnership for Health to really figure out what community orgs we should be reaching out to, and who we could help also give information to back, because a lot of this was also providing them information about disaggregated data on the CHAS as much as we were able to disaggregate. And some of the stuff that we heard from our phase 2 engagement is that identity is complex and very generational. You know, someone within one family who's 65 might have a different kind of relationship with their identity as someone who's 30 or younger. And that was very interesting to hear. And as they age, you know, what are the implications of how identity changes over time? That was another really rich conversation we had with many individuals. Culturally competent care has a big impact on behavioral health care utilization. among Hispanic or Latino individuals. And if they have a negative experience, what are the implications of them going back and actually accessing care? There's fear and mistrust among different public benefits and other kinds of programs. How an individual accesses care is based on their cultural context. And they also noted that having disaggregated data could help them be used for educational tools to help affect outcomes downstream. So really rich information that we heard. This is not everything, but these were some high level themes that we heard from our conversations. And then in phase 3, we really wanted to understand that lived experience of actual community members within the Hispanic Latino community. What does it actually look like when you're trying to access behavioral health care? What does behavioral health care mean to you? Because what we found from our analysis was that many Hispanic or Latino patients had similar rates of diagnosis for those different 4 different behavioral health care conditions, but we saw that they were less likely to actually use behavioral health care. So what structural or systemic barriers are getting in the way of people within the Hispanic or Latino community actually getting the healthcare that they need? And so we engaged with 11 different community members and 2 different behavioral health providers and spoke with these members to understand their experiences with accessing behavioral health care, to really understand the barriers that were making it difficult for them to get the care that they needed. And kind of an overall finding was that for Hispanic or Latino Coloradans with behavioral health conditions, access to needed services is really not easy, and getting quality and culturally relevant care can be an even greater obstacle. And that cost of care is such a big barrier for so many people within the Hispanic or Latino community that if they don't have access to the right kind of insurance coverage type, or if they're uninsured, there was a lot of discussions around uninsurance and access to needed care and just overall cost. That was a resounding thing that we heard from community. So again, all 3 of these community engagement strategies throughout the last 3 years, over 3 years of work for this project, was really trying to inform the next phases and where we thought to go next for the different kinds of things that we were investigating, and really getting the information that is most relevant to community groups for the different community members that they actually serve. This was a big priority, to make sure that the information that comes out of this is actually relevant and actually informative to the work that everyone's doing, and will hopefully eventually lead to some outcome changes or some policy or programmatic changes as a result of this. When we're really thinking about culturally relevant care, there's some levers that we have there that we can actually, employ to make something change here. So just some final thoughts I wanted to kind of leave with everybody when we think about community engagement for this last part of the conversation is, again, data can only tell part of the story. So we collect data from people, and their lived experience is really important to understand how they're impacted by all these different factors, and what their identity means for how they kind of move through the world, and what systemic issues get in the way of them being healthy. And really showing value to community and community groups and paying them for their time. That was something that we really wanted to make sure was in the budget, was that we could make sure that we gave back to the individuals that were giving us stories, because sharing these stories with us can often be re-traumatizing. And definitely plan ahead and be thoughtful. Make sure that you give yourself enough time within your project to scope, to engage with community more authentically. A lot of the times we have, short deadlines for some of these things, and we wanted to make sure that we were able to do more thoughtful engagement. And of course, we can always do better. So this is just something I'm always thinking about, is how to more appropriately scope for always bringing community voice into the projects that I do. And this one was very important to make sure we had lived perspectives for what most meaningful kind of approaches could be for the different kinds of things that we're thinking about for research. And I just wanted to kind of pop in the chat and let you all know that we have some resources available for everybody on the call today. So everything that I've talked about today is from all 3 phases. We have the feasibility assessment, we have the methodological approach, as well as the final results paper. It's all available on our website, which you can use this QR code, or I just popped the link in the chat as well. And for more information about the actual results, I did a webinar, I think 2 months ago, where I went more in depth about the actual report itself for the application of the methods. So check those out, check out some of these resources, and feel free to reach out to me or others at CHI's team if you have any questions, or if you want any more information about some of the data that's available and how we kind of approach this stuff. So that's all I have for everybody today. I believe AJ and I are going to kick off some questions and kind of chat with you all today on the call. But thank you so much for tuning in today to see some of the work that we were working on in Colorado. And I am excited to hear from you all. Oh yeah, thanks Tiffany for sharing that. I just reshared it.
AJ, we're not able to hear you.
I believe, yeah, Tiffany, will a recording be shared? I believe so.
Yes.
And we can also share my slides and share all these links and stuff afterward as well.
Awesome. Why don't I get started on asking a few questions? Ooh, taking the questions. While AJ joins, hello everyone, I'm Tiffany Lopes, the Director of Communications at the UCLA Center for Health Policy Research. Let's get started with the first question.
Oh, AJ's back too.
Oh, we still can't hear her though.
Yeah.
At what geographical level were the data collected?
That's a great question. So all of the different data systems do have county level data available, and the all-payer claims database, it kind of matters what kind of granularity you're interested in, but like the limited data set that is available for research that isn't kind of the protected data set has health statistics region available, which in Colorado is 21 different regions and conglomerations of different counties. So a lot of the times the health statistics region in urban areas represents the county as well, but in a lot of rural areas, it's kind of aggregated to a couple different counties. So there is some data granular at the county level across the different systems, but because of limitations of kind of that sample size that we were working with in the CHAS, I decided just to kind of look at rural urban for the model itself for this one. But all of the different data sets have that kind of data available based on what kind of research you're kind of looking forward to do. And some of them have zip code as well. So you can do more granular geographic analyses.
Awesome. So this person asks, I'm not following how the data set was labeled when you're looking for data you don't have. For example, when you're training the model to predict Chicano status, where is the Chicano label coming from in the first place?
As in the identity measure?
I believe so.
So that is, so the Colorado Health Access Survey is what collected originally the 6 different identities. So Chicano was one that our community partners were really interested in gathering. So those are the 6 different outcomes of interest that we used, where all of those, Chicano being one of them as the outcome for each of the different models that we developed. But yeah, the CHAS is what actually collects that. So we have the percentage of individuals in the CHAS that say that they identify as each one of those 6 different identities.
Did you have community groups or some sort of an advisory group providing input throughout the whole process, all the phases? Curious about their feedback as you embarked on the work initially and how they might have helped guide the modeling work.
Yeah, that's a great question. So we didn't have anything established like an advisory group, but in each one of the phases, we engaged with at minimum about 5 to 6 community orgs that helped us kind of figure out what we wanted to do either for that phase or the phase afterward. So I was less involved in the actual survey tool development in that 2021 part. It was a little bit before I got involved, but we did engage with, I think, 6 different Latino and Hispanic serving community orgs that helped us identify which identities to even add on the survey in the first place. So that's what they helped guide that. They were the ones that helped to guide and craft the actual identities that we gathered on. And then in phase 2, we really wanted to make sure that what we're hearing from community helped kind of inform the work for the modeling process. So a lot of our conversations is what guided me to not create a racial mutually exclusive variable, but to keep it not mutually exclusive, because identity is so complex. That's something that we heard often. And just recategorizing people from what they originally said to different groups, like how if we pull everyone out who's Hispanic or Latino, but don't allow it to also be, I'm Hispanic or Latino and I'm Black. I'm Hispanic or Latino and I'm Asian. So I wanted to make sure that that complexity of identity was captured in the covariates and metrics that we had available. So that was one way I was able to employ that based on the conversations that we had with community groups. And then at the end of that process, we sent out the final report, and I made them a data extract with all the data that we had available on the CHAZ to talk about all the information about the different sub-identities that we were able to report on. So it was my intention to definitely give them something at the end that was informative. And then at the end of phase 3, we provided that same report to all the different orgs in the Metro Denver Partnership and other kind of ambassador programs that we work with at CHI that specifically serve Hispanic or Latino communities. So we tried our best to make sure that the orgs were informing us and helping craft some of this, but I definitely think we could have done a better job, of course, always, to make sure that we engaged more folks. Because again, in that question, who's missing, and we don't know what we don't know. So that's one aspect that as we move forward, I would love to have an advisory group to really craft research as we move forward.
Awesome. I'm interested in the approach you chose of using 6 separate binary models than a single multinomial model. It has the advantage of allowing for using separate predictors and doing the ROC analysis, but dollars to donuts, if you take the predicted probability of belonging to one of the 6 groups, they don't sum to 100%. Is this right? Do you impose some kind of additional restraint to make the different groups sum to 100%?
No, I left them individualized, because this was something I was thinking about too, is how do these identities kind of interact at the end as well, So I wanted to keep it as flexible as possible. And, I think future steps would be to kind of investigate some of these other approaches in the modeling availability. But at that point, when I was working with some of our statisticians, we decided to keep them separated, just to kind of also make it available to say, as similar approach to the racial category, to not recategorize race, but to kind of leave it open where someone could identify as Central American as well as another one of the different identities, because we know that those are also not mutually exclusive, and you can have people in each one of those buckets. So I think I wanted to leave it open to also be able to say this individual in this model, they are predicted to be this identity as well as this identity. So thinking through that process was a lot, but yeah, that was kind of the idea of that as well.
How do you handle or account for participants with 2 or more races?
Mm-hmm. So yeah, that's where we people who identify as either one, whatever kind of racial categories that were available in the O and B categories for each of the data sets. Sorry, I just lost my train of thought. It's where, because they're not mutually exclusive, if one individual says that they identify as Black or white, or if there are other multiracial categorizations, they will show up in each one of those, so that they're not kind of pigeonholed into one identity, but to try to kind of keep that complexity in there. So yeah, if someone's multiracial, they'll show up in each one of the different categories that they selected.
Thanks, Lindsay. I think AJ is able to talk now. Let's give it a test. We sure can.
Okay. Okay, thank you. I'm going to jump back in with some of these questions.
One of the questions was, age was included in all models. How is age useful in predicting these identities?
Yeah, so age was included, and I was thinking through this as well, and I think it has something to do with potentially that generational difference as we think through identity for each of the models. But each one of them were very highly predictive and were kept in the model. I would say, you know, I think part of this is, you know, I really like that question because I think the relationship of age with identity, it kept making me think through this generational concept that we heard a lot from community groups, and that, you know, as we think through, especially the ones that, you know, we weren't able to move forward with Chicano or Latinx, but those two identities in particular are kind of around a more like social and political aspect of identity versus when we think of country of origin. So I was thinking through what that relationship might be for age when we think about what are the kind of demographic profile of someone who identifies as Chicano, which is a specific kind of, you know, political and social identity, versus those who identify as Latinx, which is a little bit, you know, newer, trying to think more through gender identity, which maybe younger individuals are more likely to maybe coalesce around that identity. So I think there's implications for, as we age, what do we kind of more identify with? You know, as a non-binary person, when I was younger, I didn't have the words or the identities that I was feeling until I got older and then started to interact with that a little bit more. So that's how I was thinking about age and when we're seeing them show up in these models. Yeah, thank you, Grace. Thank you for your comment. Yes, as a Mexican American, thank you for taking age into consideration. Age very much may guide how we identify. The way I identify now differs from how I identified when I was a young college student. Yes, thank you so much for that. That was a lot what we heard when we think of multi-generational families, you know, when we think about even behavioral health care access and how people identify with and talk about behavioral health care, but even identity itself within a family can look very different how people identify. So I thought that was such an amazing thing to hear. And thank you, Grace, for also sharing your experience as well.
Thank you. So I think you've kind of touched on this already, but we have some questions about what's the difference conceptually between Mexican American and Chicano?
Yeah, that's a great question. So this was something I talked with community groups about as well. And I think, so just for context, in Colorado, I think it's like 75 or 76% of the Hispanic or Latino community is Mexican or Mexican American. So a large portion of the Hispanic or Latino community, that's how they talked about the majority. When we were talking to community groups, they described what it's like as a different kind of Hispanic or Latino identity being a part of a different majority Hispanic or Latino community, which I thought was a really interesting concept. You know, if you're Dominican, how does that mean you kind of relate to the Mexican American majority in Colorado? What are the language implications for that? As we know, dialect is very different based on where your family or where you're from, based on the dialectical changes. So I think there's a lot there when we think about Chicano. When I looked into the demographic profile, they're more likely to be men and more likely to be older. So I think it really had to do with coalescing around a lot of the migrant rights and farmers' rights activities that were occurring, not just in Colorado, California. You all know this, a big push during that time period, but community groups thought it was important to kind of collect on that to see how many people identified with that specific social/political identity. But at the same time, an individual could say, I identify as Chicano, and I also identify as Mexican American based on whatever their kind of identity preferences that they report on. But yeah, that's a great question because I think they're related, but I think it speaks a little bit more to a political engagement and how you identify with that in a specific time period, and what that means for implications for your children as you age and talk about your identity. You know, what are the implications for that in a family dynamic?
Have you crossed this data with the federal OMB racial categories? For example, those that identify as Latin or Hispanic and American Indian Indigenous and other races. This is a serious concern for is top coding ethnicity and disappearing the AIA and Indigenous people groups?
No, that's a great question. That was kind of another, a reason why we wanted to make sure that ethnicity and race were both captured and kind of added complexity in the model so that if someone did identify as American Indian, it would also show up, and it would also show up if they, within the Hispanic or Latino community. So there will be overlap for those who identify as both on the CHAZ. But again, this all has to do with self-reported data. So we know that it's what is available to the individual to actually choose as options will always limit our ability to actually research what's going on at the end of the day. I think I've compared now that the census has been doing a lot more public facing disaggregated data on their data landing platform. That's been really exciting to see, because now we can actually look into the individuals that actually identify as Central American and actually disaggregate that even further. So I think that's one of my next steps. I really appreciate that comment, is to kind of see how I can connect all this to more of the disaggregated data that's available from the Census Bureau, because it even changed from the 2022 extract is even more disaggregated than what they released for the 2021. So I would definitely put a little shout out there for people to check that out, because I've been working a lot with those data for not just this project, but for the Asian and Native Hawaiian and other Pacific Islander populations. We've been doing that a lot with understanding what's available from the Census Bureau.
Thank you. We are at time, but we do have still quite a number of people on. Lindsey, if you have a few more minutes, we'll take a few more questions.
Yeah, I can hang out.
Thank you. Are the identity groups mutually exclusive? Meaning, what if someone chose more than one identity?
Great question. So they're not mutually exclusive. So they are able to identify as however many identities speak to that individual when they're answering the survey. So there is some potential for some overlap in the outcomes if we predict the likelihood that someone is South American and they also identify as Central American. So that is a possibility.
Great, thank you. What if the percentage of certain ethnicities of the total population is minuscule? How relevant would the findings be for particular ethnicities? Would it be for the state policymakers if the numbers are really small?
Ooh, that's a good question. Because, so much of this work is to make sure that no community is, invisible. And so I think a lot of the focus of what we've been thinking through is when we're thinking about small populations, I think that's one of the limitations of this approach, at least this first time, because we only had a single year of data. So my hope is, for future work, that I'll be able to combine the data that we collected for 2021 and also 2023 to increase sample size to potentially disaggregate some of the other identities that we collected on. As many of you might have noticed, we did decide to aggregate Central American and Caribbean together so that they were researched in this project, but we didn't have a high enough sample of them to make their own model. So that's one of my goals, is to actually further disaggregate the identities that we currently have to say something more specifically about the identities that are captured. So that's definitely a limitation of the data that we had available when we first did this modeling approach, because we didn't have 2023 data yet. But yeah, it's a great question, because no matter how small a community, we want to make sure that they feel seen and visible in the data that we create. So I think that's always a priority. But of course, when we run into small data size, that's always going to lead some issues when we think about reportability, when we think about representativeness. I think representativeness is a big one. But yeah, I just appreciate everybody's really thoughtfulness on all this. Lots of really great comments and questions.
You described culturally competent care as an important finding. Can you describe how you defined it as opposed to culturally sensitive care and literature on this topic?
Yeah, that's a good question. We've been kind of saying culturally competent care. We've also been using culturally responsive care a little bit more, because that feels more like upfront. Than competent feels like a little bit more like minimum we did this, versus like responsive feels a little bit more proactive. So I would say for us, the way we've been thinking about that, at least in Colorado at CHI, is the ability for providers to actually have the ability to connect authentically with their patients. And it doesn't have to just be with cultural or racial or ethnic identities, but we've also been thinking through this with those who live with a disability or those who have a gender identity that's not, binary, and how this relates to LGBTQ plus care delivery in general. I think it's such a wide swath and can cover so many things. But yeah, we've been also been using responsive, but that's kind of how we've been thinking about it, and how that kind of interplays with experiencing discrimination based on those identities when you access care, or feeling like your provider isn't taking you seriously. A lot of those things on the other end, those negative aspects, is what we're trying to fix or try to help solve with culturally responsive care. I guess that's another way to frame it.
Thank you. Can you talk a little bit about effect size?
Yeah, so for this round, out of I think the sample size was about 10,000. I don't know why I said about, it's 10,450 because I just remember that from the top of my head. And we had, I think 1,500 of that 10,000 sample, 1,500 of them identified as Hispanic or Latino. So that was the sample size that we were working with for this first round. And in the second round, if we were able to combine, that would mean, like 3,500 or so, at least a little bit more if we did 2023 combined. But yes, those are the sample sizes we're working with. Yeah. It's like, you're like, I think, when you say I think, even though when you know it, you're just like, I think it's this. You're like, well, no, I know it. I love that. That makes me laugh.
All right, we're going to take one last question. There
Okay.
are still several other great ones in there, and I apologize for the ones that I didn't get to, but I think this is maybe a good one to end on. And I know the answer to this for you, Lindsey, but please share it with us. Have you or your team started thinking about how the new updates to the OMB race ethnicity standards as of 2024 will impact or guide your work moving forward?
What a great question, AJ. Yes, this is such a big topic. This is so important. And this is also interesting because, back in 2021, we decided back then to add Middle Eastern or North African kind of preemptively to our survey. So I think at least for the CHAS, for the Colorado Health Access Survey, this will be interesting to see how we can kind of see how our outcome of adding that relates to what we see in updated data as we kind of move forward. But this is going to have huge implications when we're talking about interoperability and kind of like connecting data that we have in the past to how, when we move forward, that they, when they changed the OMB categories, I think in the 90s, this was another, conversation that they had to have too. And there's some statistical approaches that folks can take, like bridging, to try to figure out like how an individual in the past would have identified if this option was actually made available to them. So I think there's just huge implications for data trendability, longitudinalness of a lot of these data. But we've been really thinking about it as it relates to, what we are collecting now and how can we better collect at CHI and make sure that the data that we're collecting represents the communities that exist in Colorado and that no one feels like they're not represented. One of my friends at work, actually at CHI, he's Iraqi, his family's immigrants from Iraq. And he was telling me that for years, when he was a kid, he identified on all the different school surveys as Asian because Iraq is in Asia. And so he, as a child, was like, oh yeah, I think I'm Asian. And it wasn't until much later when he's, a young adult or, in high school that he was like, there's just not an option for me. And I don't relate to the Caucasian section that usually I am like, when they get aggregated, a lot of the Middle Eastern and North African folks get put into Caucasian, which we know isn't representative. But he said he struggled with that for years because he felt so unseen. So there's just so many dynamics and implications for not just data, but also now people feeling like they actually feel represented in data. So I think there's that social context as much as the data context now. So there's a lot of positive, but I think there's a lot of things we got to think through about connecting data across time. That is going to be interesting to see what the Census Bureau statisticians decide to do with the data.
Lindsey, thank you so much. This has been such a fantastic presentation today. To everyone, please reach out if you want the recording or the slides from today's, and visit CHI's website for more information on all of the pieces of documentation and the findings from this wonderful work that they have done. And we hope that many of you will look for ways to maybe adapt this to your own work, and we would love to hear more about that. So please stay in touch with us. Thanks, everyone, and we'll see you at the next webinar.
Bye, everybody.